Manu, back in the studio.
Finally. Gosh,
it's been a
while. Like, what, 4 or 5 weeks?
Yeah.
2 major conferences.
Yeah.
It's been fun traveling around with the camera, but it's always nice to come home to the studio.
And do a bit of work.
That too.
So we haven't posted an episode from here for about 6 weeks, I think.
Yeah, it's been a while.
And there are a couple of episodes in the editing suite as we speak, from APCCC in Lugano and from EAU and from something else I can't remember, but we will drop them in the feed. But this one might get to you before some of those European meetings make the feed.
Lots of conference highlights coming up. They were fantastic.
Yeah, EAU this year in Paris was really, really enjoyable. It was nice to meet friends, of course, as ever, but I thought it was a really, really high quality scientific meeting.
Absolutely. And APCCC always, fantastic meeting.
Yeah.
Lots of great speakers and every controversial topic you can think of, really.
So please watch out for the APCC ones in particular, because regular listeners and viewers will know that we plugged that meeting quite a lot over the past 6 months, saying this is a great meeting, please go to it. We even sent 3 of our listeners to the meeting.
It was fantastic to have them there, and we in fact saw a few more residents that came as a result of us banging on about it.
Yeah, so for Rory in the UK, who said he came to Lugano because he listens to GUcast, well done to you, and it was nice to meet you and some of your friends as well.
Yeah. For sure.
But we're back in studio and we're
back
talking about prostate cancer, and we've got a guest in the studio, which is very exciting, of course, as ever, to have a fantastic...
We brought it home from APCCC.
We did. Dr Alicia Morgans, GU medical oncologist from Dana Farber Cancer Institute. Thanks so much for dropping in.
Well, thank you for having me, and I wish I had come from APCCC, but it was lovely to come to Australia and visit you on your home turf.
Yeah, it's so great to have you here, Alicia. And, I'm usually, coming to an interview with you for Euro Today or something like that. So it's kind of bizarre to have Alicia in our studio in Melbourne.
Yeah, because she's very well known for anyone who works in GU oncology area, prostate cancer in particular, but especially as one of the really important contributors on Euro Today, which is one of our favorite resources for education in urology. And that still keeps you busy. Euro Today is still a busy platform.
It is, and it's interesting. I'm sure you feel similarly. You can be very, very busy, but because you're having so much fun and you're learning and you're talking to friends, it's actually just a wonderful experience. So love to continue to do work with Euro Today.
Absolutely, and you should. You're so good at it.
And hello to Gina and all the team at Euro Today and PCF. We're big fans of yours as well.
Definitely.
But Alicia's in Melbourne, in Australia, actually, for a few days on a speaker tour talking about advanced prostate cancer. So that's what we thought we'd talk about today. Renew, we're going to pick her brains about, we thought we'd talk about the 3 biggest challenges in metastatic prostate cancer.
Absolutely, especially
years.
Off the bat of APCCC. I think these things are very important to consider.
Totally right. So we've got 3 things. So we hope you'll enjoy this conversation, picking Alicia's brains about 3 big challenges in metastatic prostate cancer. And we'll probably meander a little bit back and forth. But the first one we thought we would speak about, Alicia, is escalation and de-escalation. And I'd written down that, a general theme in oncology is combination and intensification. And we've seen that in many disease areas over recent years. The idea of combining therapies and intensifying therapies can really lead to meaningful improvements in survival for patients. But of course, the more you intensify and combine, the more we may have side effects, or certainly costs go up. So an opposite, a balancing off theme, if you like, is what about de-escalation? What about patients who maybe have had an excellent response to some treatment for their metastatic cancer? Can we afford to do less or take a break and stuff like that? So escalation and de-escalation. Yeah, what are your thoughts?
Yeah, I think it's so interesting because our clinical trials are really built around the median response and the median overall survival, the median progression-free survival, but that does not capture all of the patients who are on the edges of those boundaries, and those are the patients where we might want to do more intensification, or patients where they're not actually benefiting from that systemic therapy or from whatever that intervention is. I think this is most striking in some of the work that's recently come out around Artera's predictive modeling, where we see that maybe only a third of patients will benefit from the use of ADT in an intermediate risk prostate cancer patient when they're getting radiation, versus maybe the rest of them who are actually being treated with ADT with no separation in their curves demonstrating disease control, so no benefit from that systemic therapy. And I think we're going to increasingly have the opportunity to use these predictive models especially to help us understand which patients need that intensification and where is the prognosis actually so good, maybe on a prognostic model, where we don't need to give extra therapy, where we can say we're going to save you from this exposure and just give you your surgery, just give you your radiation without having to intensify that further.
So important, isn't it? And not just for prostate cancer, actually, many other malignancies, I think these are important considerations. But in particular for prostate cancer, I think, we've all been caught up in this dogma of, you've got to give your best treatments up front for aggressive cancer. Yes. But at one point, we do have to just take a step back and look at how these patients are responding and see, well, is it time now to take a break? Let them recover and see what the result is.
Yes, and I think, our imaging modalities are giving us the opportunity to do this, I think more so than we could have in the past. That and such effective therapies. So when we have patients with oligometastatic disease, for example, who are identified on a PET scan, in our clinics at least, we're often trying to hit them really hard with best systemic therapy and then maybe radiation to the prostate and metastasis-directed therapy, and we talked about this at APCCC as well, just really intensifying, and then stop treatment after a certain period of time, let testosterone recover, and see if we've done enough. Is that intensification up front really enough to not just shift the trajectory of the cancer, but maybe cure some of these patients, and then give them the opportunity to live without all of that burden of systemic therapy.
Absolutely. And I think, Declan, we're also seeing in some of the clinical trials, especially looking at radioligand therapy, we're looking at sort of adaptive dose protocols even during the trial, which I think is really interesting to see. In particularly the NCP trial that looked at the combination of enzalutamide and lutetium PSMA, it was all adaptive dosing based on imaging response. And I think that's important to build into clinical trials as well.
Absolutely. If we can adapt to the patient's needs, whether it's based on molecular factors or imaging or whatever it is, then we're really being patient-centric in a new and even more elevated way.
And I think the whole ADT question is very, very important because, and as we often talk about on this podcast, these effects of ADT can be very, very devastating. And regular listeners will know our friend Tim Baker, author who's been on the podcast a couple of times, when he wrote about his experience of ADT in his 50s, like devastating. And it's not just for younger men. Even being on ADT for 2 years for your high-risk prostate cancer radiation in your late 60s or whatever can mean that you're having the side effects of the ADT running for years and years into your 70s with a lot of effect. And I know you have a big interest in survivorship. So do you think this is one of our challenge areas in metastatic prostate cancer, is to really try and better figure out who needs to be exposed to ADT and for how long a period? Can we scale it right back, knowing that we'll improve quality of life for men if we can restore testosterone?
Absolutely, but I really think it's not just quality of life, because some patients, I think we've all treated patients with ADT and seen the unfortunate cardiometabolic and habitus type changes where patients gain a fair amount of weight around their belly, that that they're losing muscle mass and their bones are certainly thinning. These patients could fall and have a fracture because they're losing sort of that central core strength, or just because maybe their balance is a little bit off. But if they gain a lot of weight, they're more fatigued, they lose that muscle mass, then they may not be able to catch up. And this could be because of 6 months of exposure to ADT or longer. But if they also then don't recover their testosterone and then don't have the energy to try to sort of build back that muscle and try to regain their strength, get rid of some of that central adiposity, these can be permanent changes that can really put the patient at risk for long-term medical complications and certainly frailty and loss of independence, more so than just even the quality of life issues that matter to them, certainly. But we worry about all of these issues when we're thinking about ADT.
And it's so important to consider, isn't it? Because the whole point of hitting prostate cancer hard and curing prostate cancer is so that they can live a good life.
Yes.
There's no point in doing that if they're going to be in and out of hospital with various complications of their treatment.
Absolutely. We want patients to be long-term survivors. And if that means that they have to be exposed to ADT to do that, I think we can support them and help them make choices to optimize their situation. But if it doesn't mean they need to be exposed to lifelong testosterone suppression and hypogonadal life, then we need to think about how do we support them to get back on track and regain what they've lost because of our treatments.
And one of the most successful examples of treatment intensification in recent years has been in metastatic hormone-sensitive prostate cancer, where we've known for a few years if we add in chemotherapy, patients get a benefit. But now in recent years, we've seen that instead of chemotherapy, if we add in AR pathway inhibitors, we've talked about them a lot on this podcast, we get a really meaningful benefit for patients in terms of their survival. So we all accept that. That's an example of intensification works really well, especially with AR pathway inhibitors. But now, Alicia, we're beginning to see some patients that maybe we started them on ADT and an AR pathway inhibitor, a year and a half ago for maybe their retroperitoneal lymph node disease, which tends to respond really well to these treatments. It's 2 years later, maybe the PSA is wiped out. So can we stop? It's a real question where trials haven't helped us yet, but we're now in that era where patients have had a great response to intensification, but they're still sort of on ADT and maybe an AR pathway inhibitor. So what are your thoughts on the de-intensifying in that setting?
Well, this is the classic intermittent therapy question, and studies in the past have actually shown that there's not an inferior loss of, there's a potential loss in terms of mortality if we're intermittently giving them systemic therapy. But those studies were done in an era where we didn't have next generation, really molecular PSMA-directed imaging, and they were also done in an era where we didn't have this intensified hormonal strategy. So essentially, I think those are obsolete understandings now of where we stand. And so there are trials that are actively looking at whether we can stop therapy for patients with an extremely robust response, whether that's a radiographic and PSA-driven response. In most cases it is, or otherwise. But they're putting forth those criteria and seeing if we stop everything, can we then allow that patient to recover and then treat when they need to have that again. And I think even in the biochemical recurrence setting, for example, where we saw, in BARC, there were tails on the curves for those patients who were treated with the intermittent intensified therapy, where some patients came off and never needed to restart their treatment with many years of follow-up. So can we do this in the metastatic setting, especially for lymph node positive metastases, where we know the prognosis is actually good in most cases as well? I think these are questions that we're trying to answer now. And I think I'm really excited that we live in an era where this is of importance to us and to our patients, and we have the opportunity and the tools to actually investigate and give them the answers that they want around what those trade-offs actually mean in terms of disease control and quality of life.
I love it. So I think we will see less, and we will see trials that are testing the idea of de-escalation. But before we move off de-escalation, I have to ask you about triplet therapy, one of our favorite thorny topics.
Yeah.
Because if you presume that in 2024, in countries where AR pathway inhibitors are available, the vast majority of men will be offered ADT and an AR pathway inhibitor for their metastatic cancer. Let's say that's kind of the ideal world.
That's the goal.
How can we figure out who might benefit from intensifying more with chemo, which is definitely toxic? Because my cynical view is, I think it's really difficult to make that argument because it hasn't been tested. The idea of adding chemo into a doublet with an AR pathway inhibitor, and the MDT this morning at Peter Mac, we were talking about an exactly classic case like this, and clearly some might benefit. But how do we figure that out, Alicia, without exposing men to toxicity that we know from Stampede may not be temporary, may be persistent?
Yeah. So I don't think we need to do the trial. We need to understand with the trial. We don't have any trial that's randomized around chemotherapy. So it's impossible for either side to answer this question definitively. There is a trial that's moving through the CTEP process in the United States that hopefully will be able to randomize people to chemotherapy or not. But the same question was asked back when Charted was developed. Everyone said, well, you know what, there are men who are having fantastic responses to a hormonal approach alone. Why in the world would we expose them to chemotherapy, and who is actually going to benefit? And that trial showed that chemotherapy was additive. Now, I am not saying that I know that chemotherapy is additive to an intensified ARPI and ADT backbone. I'm just saying we don't know. And especially when we have patients who are young and fit and who want to do everything essentially for their cancer, I don't know that removing the chemotherapy is actually going to be safe in terms of potentially compromising their disease control. And I think, so it's young and fit people, but it's also those people who have those molecular markers that suggest a more aggressive disease and those clinical factors associated with poor prognosis. I don't know the answer, and nobody knows the answer. But are we willing to compromise for patients who want to do everything, who want to kind of push the envelope and say, I know for sure well enough that there's no benefit from chemotherapy. And I don't have that knowledge, and that's why I use the shared decision-making process to let patients understand that I don't know, that we can do this, we can do that, and try to let them help guide us, because I don't know what I would do for myself, and obviously I don't have a prostate, but if I were in a situation where I could intensify but I wasn't quite sure, maybe I would choose to do that, maybe I wouldn't, and every patient is going to have a different preference on that line. And I don't want to be so autonomous that I say, well, I'm just going to shield you, patient, and I'm not going to even talk to you about it, because that's not the right answer either.
I guess, Alicia, the question is, I mean, rather than throw, the kitchen sink at them in the first chance, just like we do a sort of a cautious de-escalation, is it possible to do a cautious escalation and start them on, duplet therapy first, a doublet therapy first, and then see what their response is like, see what their PSA kinetics are doing, and then make a decision about adding in chemo?
Sure, in a trial. You just don't know.
Yeah.
So let's think about the non-metastatic CRPC setting, for example, where we had patients who were getting, ADT plus placebo or ADT plus one of the ARPs. And in those settings, many of the patients crossed over on progression to the ARPI when they were on placebo. Not ubiquitously, but many of them did get an AR pathway inhibitor. And the delay in that time actually led to a survival difference. And this is an early state. This is non-metastatic CRPC. But this delay in initiating that appropriate intensified therapy led to survival difference. Do we know that the delay in time to chemotherapy will lead to a survival difference or not? We don't know. And so that's why I think the trial needs to be done.
Absolutely.
Great. Next topic. So what's my take home on that? I think escalation clearly has a very important role, and we've figured it out pretty well. But de-escalation is an important priority for clinicians and patients. And if you have de-escalation trials in your centre, let's support those trials.
Absolutely.
Let's see,
Yeah.
On a similar theme, the second challenge we identified, Alicia, is about precision oncology and imprecision oncology. And of course, everyone likes the idea of precision oncology, of having a cancer situation where there's a test we can do that will mean that individual patient is highly likely to have a response, so-called precision, whether it's gene testing or some sort of biomarker or some sort of imaging test. And I suppose, Renew, at Peter Mac, we see that a lot in advanced prostate cancer in radioligand therapy selection when we're trying to select patients for lutetium PSMA. Our view in Australia
imaging
has been
biomarkers.
imaging biomarkers.
Absolutely.
Right. So if PSMA PET showing some cancer, but we also do an FTG PET.
Yeah.
But it's a kind of peculiarly Australian thing. This
Notoriously Australian thing.
Because in the US, most rest of the part, we just do a PSMA PET.
Yeah.
So I think, what do you think about this area, first of all, in radioligand therapy? We want to talk a little bit about PARP inhibition and ctDNAs as well, but what about imaging for selecting patients for radioligand therapy? And you were at our MDT this morning. We saw some great examples of conundrums, but what's your thoughts on that?
Well, I think it depends on what the ultimate goals are and what the options are for patients. So, you are selecting perhaps more cautiously when you're doing both scans, and you may be optimizing for that best response. But if you are doing both scans and you're excluding another percentage of patients, then you may be excluding some patients who could have some degree of benefit, just because you have that sort of discordance in your scans. I don't know necessarily what the right answer is, but I think this is the situation where, similarly to our last conversation, it comes down to the right answer for that patient. We don't always have the choice, though. I mean, you have your situation and I have my situation in terms of making those decisions. But there are some patients who would say, I would be willing to take the potential toxicity of 2 cycles of lutetium PSMA 617 or whatever the agent is that you have that's targeted. And I'd be willing to take that toxicity even though it's possible that I will have no benefit. So just do one scan, give me the opportunity, if that scan is positive in the proper ways, consistent with vision, as an example, and let's see how it goes, and we'll reassess after 2 cycles. There are other patients who would say, I won't take that toxicity or have no interest in that toxicity if there's any chance that I would have toxicity without benefit. And those are the patients who may choose to go all the way in the direction of the PSMA PET and the FDG PET. Many of our patients are somewhere in the middle. And so it's up to us and the way that we help counsel them to try to get them the right answer. And ultimately, it may not even be up to us. It may be up to our centers and the way that these patients are kind of discussed in an MDT. So I don't know what the right answer is. I just know that there are different ways to get to the answer. And it is stressful to think that there are some patients who may not have access, even though they could potentially benefit. Also, of course, stressful to think, as in all of oncology, there are patients who are exposed to things that are not going to be helpful to them. And so we just have to do it the best within our system and try to get access for those who we think can get benefit.
And the added financial toxicity of these treatments as well. You know, they're not cheap treatments. And
yeah, it's a good point, especially if you're going to have to fund this treatment yourself, and there's going to be a $10,000 thing, and maybe it's worth having that extra PET scan, which is a lot cheaper, to see will I optimally benefit or not. So I just think, so it's very attractive, the idea of an imaging biomarker. So these are very colourful. There's the cancer and it lights up and the lutetium goes to it. But what about that bit of cancer over there and maybe my liver that doesn't respond? And I think there has to be a balance, because just to give people some context, in Australia, certainly in our centre, if you're being in that situation where lutetium has been shown in randomised trials to work, if you have both a PSMA and an FTG PET, you have about a 30% chance in our centre of being excluded, because there'll be some discordance. The two scans are showing something a bit different. And we will say that we think you're unlikely to benefit. Whereas if you're in the US or Europe and you're only doing a PSMA PET, based on the VISION study, really good quality studies, you've only got a 13%, 10 to 13%. So you're 90 odd % chance you're going to have it. And there's a benefit. So I think there must be somewhere between the 10 or 13% and the 30% renew that, you know, we need to make sure we're not excluding patients who might benefit.
Yeah. And the other interesting thing that came out of the biomarker paper that James Buteau did after the therapy trial was that, you know, discordant disease and high volume of disease on FTG PET also predicted a worse response to chemotherapy. So it really was kind of an important bit of information that you could get in terms of counselling patients on how they're going to do and look at other ways of treatment intensifications for those specific patients.
It's hard too, because there's no biomarker, whether it's a blood-based, tissue-based, or radiographic-based biomarker that's 100% perfect. There's always some degree of gray, even in the biomarker and in the interpretation. So I think we have a lot of ways to go in terms of trying to properly select for our patients, but it is really quite a conundrum, and of course a good one to discuss today.
And the other precision oncology area that you're very familiar with is for PARP inhibition for patients, and this was sort of the first example of a proper precision oncology approach in prostate cancer when the PROfound trial read out, and it showed that these patients with metastatic CRPC who had a DNA repair defect benefited from olaparib. So it was very, very targeted. You're only getting the drug if you've got this particular genetic defect. So a really good precision oncology thingy. And this is still an evolving area with different PARP inhibitors and combinations with AR pathway inhibitors, etc. But we have challenges even with the current status of testing patients, because often we're being asked to find one of these mutations, Alicia, and sometimes it's based on a patient who had a TURP 12 years ago and we're trying to dig out these old specimens and test them, or we're trying to find some metastasis that perhaps the patient might be prepared to have a biopsy and so on. And we're still trying to figure out, will liquid biomarkers, ctDNAs replace it? So for PARP inhibition especially, what's your current take on how we select patients and challenges with testing?
Well, even before we get to that, just to acknowledge that even among all of those mutations that were included in the PROfound trial, there seems to be a differential response to PARP inhibition among all of those mutations, with BRCA2s, of course, having the strongest suppression, PALB2 similar perhaps, and then there's everything in between. And we even found PPP2R2A, actually, those patients seem to do better on the control arm than they did when they were exposed to olaparib. So at least in the US, it's kind of acknowledged that if you find that mutation, don't put those patients on a PARP inhibitor. Wow. So, or at least on olaparib that was included in that trial. So that's sort of just thinking about differential response to all the identified mutations. But to your point, it is not always easy to even complete the genetic testing. And there's somatic and there's germline, and which one do you do, and how do you deal with old specimens, and can we use liquid ctDNA as well? I think at this point in time, we're basically trying to do a hierarchy, and it's recommended in the US that we do both germline and somatic testing, which is not always necessarily even feasible within a practice, but luckily is something that I'm able to do in my practice. And when I think about germline, that's a little bit easier, but somatic testing, we're prioritizing trying to do fresh biopsy in a hierarchy. Next would be perhaps prostatectomy specimen or a tissue specimen if it's available within a reasonable amount of time. And then we are using a lot of circulating tumor DNA testing as well. And we acknowledge, of course, that there can be CHIP interference, especially if you're finding ATM mutations, that is going to be a false positive. And then, of course, ATM mutations may or may not actually respond to PARP, so there's that issue. But it's all just a bit of a fishing. This is exactly what I meant when I said that even when we do our biomarker testing, none of that is perfect. And we may find what looks like a pathogenic mutation, but it's only present in 0.1% of cells. So is that actually driving the cancer? So much for us to learn, and an opportunity for our molecular tumor boards to get together. And when we don't have those opportunities, it's a lot for the clinician to kind of think through and figure out for that patient in front of him or her.
And prostate cancer is so challenging because it is so heterogeneous. And you know what, the situation when patients have localized prostate cancer may not be the same as when they have metastatic hormone sensitive, and then it may change again when they have castration resistant disease. So I think that's why ctDNA and circulating biomarkers are a really exciting field of study. But if you are relying on tissue testing, at what point do you think we should test these patients?
Well,
should we be testing the radical prostatectomy specimens?
Well, a lot of times the PARP-sensitive alterations, so the BRCA2s and the PALB2s, these are truncal mutations, which are typically going to be present in the prostatectomy and lead to that initial cancer. And so, again, thinking sort of through the hierarchy of availability of tissue and relying on tissue preferentially over a ctDNA test, I think we are still sending prostatectomy specimens. But I think to Declan's point earlier, sometimes it's not an ideal specimen. Perhaps it's from 15 years ago. Perhaps it's at a center that's not related to us and we're having difficulty sort of retrieving that specimen. So there are challenges there. But because many of these are truncal, we can, I think, in many cases, especially if we don't have access to a new biopsy, we can think about using it, recognizing that it is, like all of the other approaches, probably not perfect.
It just makes you think, if you're dealing with a patient who has a very aggressive cancer at their radical prostatectomy, should we be thinking ahead?
Thinking ahead, it's a great theme. And someone spoke to us about this recently, Alicia. Sometimes we have an older patient presented with metastases, like one of the other ones we discussed actually this morning at Peter Mac, in retention, and we haven't got any tissue. So we want to get on some treatment. And you might say it makes no difference knowing if it's Gleason 8 cancer or whatever, but it can make a difference in 4 years' time when the patient's still doing well but castration resistant, and we need a bit of tissue to test for a PARP inhibitor or something else. So I think for urologists, that's part of our theme, is like think ahead and get adequate tissue. Get those good TOR chips, or go and do a biopsy. So thinking ahead is one of the themes we've come up with in trying to plan for a future of precision oncology, is that we might need that tissue to help you guys and girls in the future.
I would say medical oncologists always want tissue. Always, always, always. So get us as much tissue as you can. Think ahead.
Totally right.
You guys and scientists, all the same.
Come on, just because you're just throwing your PhD, she's under PhD pressure, by the way, everyone at the moment. Can you all have a spare moment for review? She's in the final stretch of her PhD.
All the wrinkles.
A double doctor, though. So impressive.
Oh my gosh.
It'll be worth it. So, final thing we wanted to talk about was something that you came up with, we were talking about last night, is recovering testosterone. We want to talk a little bit about the theme of recovering testosterone. So we've talked earlier in the podcast about trying to limit the amount of ADT, or maybe de-escalating after a little while. But of course, for some men, it can take a long time before testosterone comes back, or never.
That's one of the things that shocked me at APCCC. Apparently something like 30% of men don't ever recover their testosterone.
After even a shot or two.
That's shocking.
Yeah.
I think, there have been multiple studies that have been coming out, GU, ASCO, EAU, and other settings, where we're really learning that even though we tell patients, oh, it'll be fine, you'll recover your testosterone, we'll move on, it's actually not always fine. And it's certainly enriched in those patients who are older, those patients who are on longer term ADT. And we really need to think about, this is potentially committing a patient to lifelong hypogonadism. Is that what we want? And is that the right thing for this patient?
Absolutely.
And it brings up the question then of accepting that can be an effective ADT. What about restoring testosterone? So this is something that we always would have been a bit taboo in prostate cancer. A patient with metastatic prostate cancer, even if we're on a treatment break, the idea of restoring testosterone, it provokes anxiety. Well, is that going to feed my cancer, etc.? But what are your thoughts? Where do you think this will go in the next years? The idea of restoring testosterone with a view to improving quality of life, but of course without having some sort of negative impact on the cancer.
Yeah, and I think to the points that we talked about earlier, it's not necessarily just restoring quality of life. I think there's restoration of the cardiometabolic status and the physical function status that can be so terrible for a patient. I think when it comes to metastatic prostate cancer, I think few people would say, unless we're in the mCRPC setting and we're using that bipolar androgen therapy, that we probably are not going to give a lot of testosterone back. But the oligometastatic setting, where we've now identified oligometastases by PET imaging, and then radiate all of visualized sites, take care of the primary prostate, usually I would think in that setting with radiation, and used intensified best systemic therapy, can those patients, when they finish a systemic therapy duration, come off and potentially get testosterone replacement? Or even those patients with high-risk localized disease who get a few years and then they stop, and some of them will not recover testosterone. Can they get testosterone replacement? And it's all a spectrum and a gradient of risk, but I think it's something we absolutely need to think about and investigate. Because if we think downstream, what's the worst thing that can happen? It's not that giving testosterone is going to create a prostate cancer in them, but it will unmask residual disease. If we can identify residual disease, if we can find it, or at a minimum, identify that it's happening and then use an intensified strategy to protect the patient by restarting treatment, I think it's reasonable for us to think about what are we really losing? Because when we have intensified systemic therapies and we have a way to identify potentially residual disease that we might be able to use an intensified systemic plus metastasis-directed therapy approach to treatment, maybe we can just kind of help people move along and give them some testosterone, give them that quality of life and physical function, cognitive function back, and let them have that disease control without compromising their long-term outcomes.
So you might actually be gaining.
Yes.
Yeah.
Value of time.
Exactly.
How would we do it, Renu?
That's a good question.
Do you prescribe testosterone?
Not for metastatic prostate cancer patients, no.
I do not, but I partner with some really great urologists who sometimes do in very select patients. And there are some trials going on. I think there's one at MD Anderson, and I think Australia would be a wonderful place to have a testosterone replacement trial because you have such a wonderful opportunity with your imaging, and you certainly have a patient population that wants to be healthy and well. So in any event, there are studies that need to be done, I think, to help us all as a community kind of get to a point of what are the best practices and how should we do this. But no, I do not prescribe testosterone, and I wouldn't feel comfortable. It's just not my role as a medical oncologist. And even urologic oncologists who are used to kind of taking out the prostate and using hormonal suppression may need to partner with maybe Men's Health or
endocrinology.
People.
Exactly.
Yes,
I think it would be integral to have people like that in the team. I mean, which we do anyway to help us with ADT.
Yeah, I think certainly for us it would be endocrinologists, but in different parts of the world, US, a lot of urologists have an interest in testosterone replacement therapy. But a lot of the patients out there listening to this podcast, because a lot of patients listen to this podcast who've been through ADT will be listening to this very intently, thinking, yeah, I would. Or they've been on an intermittent approach, but they've been waiting a year for the hot flushes to go away, and we're still looking at the testosterone very low. Would be very attractive. In fact, we're probably going to get phone calls on Monday about it. But if you think that, especially with intermittent approaches, our approach there is we want the testosterone to come up. We're quite happy for it to come up and see what happens. Why not just bring that forward? I think we don't even need trials necessarily to do that. If you're on an intermittent approach, to say, we can do that. We're just going to watch you very carefully. We'll partner with our endocrinologists. I must say, listening to you talk about that over the last few months, I'm really keen on this idea that if we're adopting a principle of intermittent, we might as well replace the testosterone. And actually at APCCC, I recall Dan Spratt talking about using Relugulix, the oral ADT preparation, because the testosterone comes back much faster.
Yes.
But then other people were having concerns saying, well, if it comes surging back and blah, blah, blah.
If it comes surging back, it unmasks prostate cancer that remains, right?
Exactly.
It's still there.
You
have not lost anything. You've just identified that you still have prostate cancer.
And now we can do something about it.
Yeah, so I actually frequently use Relugulix in a setting where I have a discrete duration of treatment planned, and especially for people who are on the border of will they even take hormonal suppressive therapy? Because there are patients who say I'm not going to do this. I know what that means, and I'd rather do my radiation without, for example. But sometimes it can be a little gateway ADT to help them sort of feel comfortable that they can manage it through, and we can get them through 6 months, and it's a discrete duration, and then testosterone will come back. And I do feel like testosterone comes back both more quickly and perhaps, not been proven, but perhaps, in patients who, if they'd had a prolonged GnRH agonist injection, maybe it wouldn't recover at all. Perhaps there's a difference in recovery, proportion of patients who actually recover testosterone when we use these different strategies.
And do you see a difference in their quality of life, in their health?
We have a trial actually ongoing called Recover PC, where we're trying to measure quality of life. I think it's challenging because there are some things that are not intangible, because that's not really the word, but difficult to measure. And we see this in the quality of life reports and things like the HERO trial, or in other settings, even Embark, where we're trying to capture things that are almost difficult to describe for a patient or any individual. And so can we capture it on a survey? So we're trying to see if we can. I do have patients who feel like they feel better, although I'm not sure that I can necessarily capture it on a patient-reported outcome measure. So we'll see.
Yeah.
I'm trying to think aloud. How will I manage this next week when I have a patient that I'm taking off ADT as an intermittent approach, or ADT doublet actually, increasingly? I'll probably leave them for a few. I'll probably check it.
Wait to see.
Wait to see.
I would wait to see.
Exactly.
Wait to see. And
Yeah.
it's part of the biology exposing
Yes.
itself a bit, isn't it?
Yes.
So
Yeah.
let's do your PSA and testosterone in 2 months, and again in 2 months. See how you're feeling. But if it's sluggish coming back, I don't think we need to partner with the endocrinologist. Maybe we'll do a full episode on it and talk about that.
Practical approaches to it.
But I think you're right. That third area
Very
of,
interesting.
recovering testosterone is a really important thing, and it'll definitely chime with a lot of people out there listening to this who have lost testosterone and hasn't come back.
What else is on the horizon,
Yeah, that's
Alicia?
3 big things. That's anything
wow.
else? What else?
You know, I think there's definitely drug development, and you know better than many about the radiopharmaceutical development that's happening. There's betas that are coming out, there's alphas that are coming out, and I heard about an interesting, what was that particle that was?
Terbium, 161, yes. Auger electrons.
Auger,
Yeah,
I
so
think
a
it was
mixture of
described
alpha,
as like he made some hand motion, and it was an interesting firecracker in the cell, I think is what he said in any
Auger
event.
electrons.
Yeah.
It's really fascinating, the radiopharmaceutical approaches, but also the antibody drug conjugates, and so they're
Yes.
trying to increasingly use those in patients, as well as cellular directed therapies, CAR Ts. So I think, you know, it's all a spectrum of what people are going to be able to tolerate, but we do have patients who are in their 50s, and perhaps those patients could get a CAR T, and if it cures them of metastatic disease, you know, if that was on the horizon, you know, there would be people, I think, willing to take on that risk and that side effect burden to get to the other side. So lots of drug development happening, and certainly a lot of interesting stuff, even in this room, talking about quality of life measures to improve for patients as well.
Yeah, the one thing she didn't mention was immunotherapy.
I was just going to say, we should end on a positive note.
That'll
Don't
be what we
open the
finish
can of
on.
worms.
Dr. Morgans didn't even mention it, so, you know, but... actually,
There are so many things to do, so many things to look into, and we'll continue to look into ways to use any approach, right? Any approach that can be effective.
Especially if we're going to, have our kind of 3 principles we knocked up over the past few weeks preparing for this. They're talking about escalation and de-escalation, getting the balance right, precision and imprecision, and the testosterone one. So all that talk about newer drugs and all that is still with the background of we're going to try and get the balance right for our patients.
Exactly.
Not just, blindly try and intensify things for the benefit of pharmaceutical companies and our own academic progress. We're going to have the patients at the heart of it. I love it.
It's awesome, Alicia, and we're so lucky to have someone like you always fighting for survivorship and reminding us how important that is. So I think that's really important.
Great. Well, that's all we have time for on this episode of GUcast. Thanks very much to Alicia for popping in during her busy schedule here in Australia. It's been great to have you, and we look forward to having you back again. Keep up the good work with Dana Farber and with Euro Today. It does remain one of our favourite resources, and we're always happy to hear new episodes coming out from Euro Today.
Definitely.
We'll be back soon again from the studio, hopefully.
Hopefully.
But we will post those episodes that we shot on the road. Just takes a bit longer to put them together with our editors and so on. But we will be back soon with lots of good content, and we look forward to talking to you again soon.
Bye.
Take care.